Hello again, this is Nick Rainey. I'm a physical therapist student at Rocky Mountain University of Health Professions. This is part two of my case on an uncommon shoulder pain. So, like I said in the diagnosis, we we could see on the previous slide is that I did want to do. I'll show you this. I did put it as yes, and I put my primary things that I thought with the ICF, and then also a pathoanatomical, pathomechanical subacromial impingement. Um, so this is the part where I do a little bit of critical reflection, answering the question is the aspects of the diagnostic process that were most difficult in this case. And at this point, it didn't seem too difficult. I did notice that AC, acromioclavicular and sternoclavicular joint mobilizations, they were sometimes painful, sometimes not, which I thought was kind of interesting. I didn't think too much at this point. And I didn't palpate due to reaching treatment threshold. Plus, it wouldn't have changed my initial treatment. I thought a lot about why I didn't palpate, and I I knew what I wanted to do. Research backed it up, and if you palpate everybody, then you can. Sometimes it's easy to get going down bunny rabbit trails and seeing things that you don't necessarily need to do. Everybody has some painful spots, especially if you push hard enough. And so I didn't palpate, although I do realize now that I should have. And it might have, as you'll see later, it might have changed my treatment sooner if I would have palpated earlier, but it wouldn't have changed my initial treatment. So this is where I get to prognosis. Well, how do I know if they'll be getting better? And obviously every patient is different, but what does the research say? What do most people do? And so I looked at impingement. Went to pubmed.gov, went to their clinical queries section, and I put a narrow, for prognosis, I put narrow parameters, put subacromial impingement recovery. And it gave me an article, Subacromial Impingement Syndrome, Effectiveness of Physiotherapy and Manual Therapy, and it looked like a really good article from the abstract and whatnot, but as I got into it, I realized that they didn't give me many specifics on time frames. They discussed what types of treatments are beneficial or not beneficial, we just don't know. But one of them, it said that was beneficial, looked a lot like the things that I felt like would be beneficial and things that I normally do as a physical therapist. And so I looked at the reference, and it sent me to a comparison of supervised exercise with and without manual physical therapy for patients with shoulder impingement syndrome. And this is actually, it took me to an article I hadn't looked at much, but I'd heard of it. It's a classic, the Bang and Dial article on JOSPT back in 2000. Basically what it said is that they used 6 treatment sessions. More of them were at the front, but then they did a pre-evaluation and post-evaluation. They were 2 months apart. And there was a 35% improvement in their function, the way they measured function. The way I measured it was an Oswestry. I put the Oswestry Disability Index, but that is incorrect. It is actually the quick dash that I used. ODI is for back pain. I accidentally put that there, but I don't want to go back and change it now, at least for this. But so yeah, I put they would have a 13. So 35% improvement in the function. What that would mean for my patient was down to a 13 in the quick dash, because that's also a disability, because he was originated at 20.5. And then also a 70% improvement in pain, which for my patient will be from about a 6 to a 2. Normally I don't do points to my patient. I think the technical one would be down to a 1.8, but I just put a 2 right here. So that's the evidence-based prognosis. These are the specific goals that I had for him. In 2 weeks, I don't want any pain with donning or doffing a shirt, and have the pain never rise past a 4 on it, 4 out of 10. Normally, I measure this for 3 consecutive days. And then 7 weeks, that was whenever I'm setting goals, I look at evidence, and also look at what the patient in front of me and my experience, and when do they want to get back, and more personalized time frames. So we put 7 weeks from initial evaluation with him. I wanted him to work on the railroad car without pain, and then again get the quick dash score down to 13% or less, and have the pain never rise past a 1 of 10 on the MPRS. I oftentimes don't like to go to 0 of 10, because then it seems like we maybe didn't hit goals. And a lot of times my patients will continue after the conclusion of episode of care of performing exercise to, finally decrease it all the way. If they're managing it on their own and it's pretty low, I normally conclude the episode of care and let them finish it on their own. But I put a goal of 1 of 10 there. Intended outcomes. I also want to demonstrate equal strength bilaterally, be able to perform a push-up with hands and feet on the ground, demonstrate equal active and passive range of motion bilaterally. Those are just kind of things I thought he should be able to do at the end. The rehabilitation plan. So these are things I planned on doing, kind of the progression. Manual therapy. I definitely want to hit the thoracic spine. We're doing basically a high velocity, low amplitude manipulation, the glenohumeral joint mobilization, scapulothoracic joint mobilizations, and then sternoclavicular and acromioclavicular joint mobilizations. Those are for pain relief mostly, because I didn't notice any hypomobility, but most of it for pain relief in those areas and just getting the mechanics to work correctly. I also like to use exercise. This is part of one of my therapeutic exercises. I want to make sure, since reaching up is a difficult thing for them, make sure the upward rotators and stabilizers associated with the scapula are working correctly. Here's some of my favorite exercises you can read here. To describe a little bit more, the serratus anterior punches, also called, I like push-up pluses. I didn't want to use push-up pluses with him, but basically elbows are extended and you're protracting and retracting the scapulas. Then lower trapezius Y wall liftoffs. Basically, they make a Y, 1 foot next to the wall, their hands are on the wall, then they bring their arms back to even with their ears. Rows are pretty standard. Rhythmic stabilization, I just have him put his hands and arms in certain positions and I perturbate them rhythmically, manually. And then just external and internal rotation resisted type stuff, either with TheraBands or manual or different ways we can do that. So part 2, I always like to make sure I get long lever movements inside of for my rehabilitation plan. I don't want to get caught up in just scapula stuff. So I make sure to get long lever. We'll start off with that active assistive. So that's where I'm helping him with his wrists as he's doing it. Scapular assistance, where I'm supporting the scapula during those motions, and then just having him do it on his own. And then eventually, progress to resisted things there as well. Where I said active, I did put that there, active range of motion and resisted for those. And then multi-joint movements. I like to progress a little bit more functionally as we get, the dumbbell shoulder press, push-ups, and dips. So I'm going to present 3 interventions here. All these I performed in the first session. They're the ones I thought most pertinent. Here's just a couple pictures of them. We have the thoracic manipulation there on the left. I like to do it seated. Generally, I find it more comfortable for the patient, and I just get a little bit better results with it. And then my acromioclavicular joint mobilizations I have pictured here. So the first intervention is the thoracic manip. The reason I performed this one was because on MUTH or MUTH, I don't know how it's MUTH, they showed that people with the 3 provocative tests, the 3 special tests were positive for me, which were Hawkins-Kennedy, NEAR, and I forget the other one that was painful for him. Let me go check that real quick. Empty can. So for that one with empty can, those 3 MUTH found that there was a 2-point change in pain, and that with all those special tests, when you did thoracic manip, I had 24 out of 30 subjects. That's part of what I was talking about earlier when I reached treatment threshold. That was the best evidence to support that, so that's what I went with. The way I assessed if it was beneficial or not was, I always like to hear cavitation. The research doesn't really back that up, but the way I feel about it, if a cavitation is possible and you don't get it, then it's not going to be as beneficial as if you do get it. And so there's really, again, there's no research to back that up, but that's my personal feelings on that. That upon retesting shoulder flexion active range of motion, the pain is no better and possibly even worse, which was not what I expected. And so when that didn't work, I went on to a second intervention, like, oh, maybe it's more AC joint. Typically, I see benefit with thoracic manipulations when I feel it's more of a glenohumeral or scapulothoracic type of thing. Or a combination of those. So I went AC joint, particularly because I'd seen, I thought was a little bit of impairment there in my examination. Performed this in supine, as you can see the picture here. Normally like to have supine kind of help stabilize the scapula there. I put my left hand on the acromion. This patient is their left shoulder, and then I use my right hand to mobilize the scapula there. I find that to be pretty comfortable for the patient. I feel like I can get pretty specific there. Start off with grades 1 to 2, and I plan on progression to grades 3 at 4, but I never actually did that, as you'll see later. Performed this for 3 minutes the first 2 sessions, and then I also performed it on the 4th session. The goal was decrease pain and increase range of motion. It didn't make it worse, but it didn't make it any better with this one either, and so I'm a little bit worried here. On my first day, I'd really like to make quick changes and get out and see them again the next day or the next time they come in. So it's my 3rd intervention. I went with something I thought would be pretty safe, and it ended up being pretty safe. I didn't expect to see any dramatic changes with it, but it's something that keep him active and help him be excited about what we're doing. Although normally with these it's difficult to get them excited, but not feel like they didn't have anything to go home with. I want to keep them active. And it's always good to get muscles working in a pain-free motion. Seated scapular retraction. We did 1 set of 25 repetitions. I did these for the first 4 sessions, and they always had it as a home exercise program. It's almost, I don't think I've ever seen it where somebody has too strong of, rhomboids or any muscles back there where it'll make their pain worse to work those. And I plan on just coming back another day and seeing if we could, figure out better what was going on, what would make him better the next time. So that leads me to my reflection on how I'm doing as a practitioner. By the 4th treatment, he wasn't any better. His pain has increased and his range of motion has decreased, as you can see, and now reaching across the body is even more painful than the other motions that we looked at. I thought to myself that this has got to be musculoskeletal because there's specific movements that aggravate it, but I wasn't on the right track. It wasn't painful at rest, but I was definitely not on the right track because we weren't making any improvements. So I started to collaborate with my clinical instructor, told him I wasn't seeing a difference and I didn't know where else to go. We developed a new different list of differential diagnoses. We've got rib dysfunction, coracohumeral impingement, coracoclavicular impingement. Can't really diagnose that clinically. Maybe that's why some of our interventions we expect to improve or not. We also found that palpation of the pectoralis major listed familiar symptoms up into his shoulder is palpably different than the rest of the tissues. So we went to trigger point dry needling. Basically, we used a needle, went medial to lateral on his pectoralis major. There's a picture on the next slide. We saw great results. Range increased and pain decreased. Active range of motion didn't increase, but the pain did. And so I think it would have increased at that same level of pain. But passive range of motion really saw the first initial quick changes you can see on there on those charts. There's a picture of the dry needling. The way I would get there quicker next time, the palpate, like I said, I should have done the first session, but I probably wouldn't have changed my initial treatment. But maybe I would have gotten there session 2 and I think that I have a little bit better evidence to help that shoulder pain weren't working. We used the quick dash. Don't want to look at this last slide too much. I think this one's a little bit cleaner. His perception of his disability didn't change according to this form, but he did tell me he felt like he was a lot better, and he obviously could reach a lot higher. We didn't reach the goal that we had hoped to have down to 13%, but that's the way it goes. We did those off the MCIDs and MCDs for those. So hopefully that, with increased use of the trigger point dry needling, we'll be able to show him that things that he's doing at home are beneficial and he'll have perceived less disability. There are my references. If you have any questions, please feel free to email me. Love to hear any questions you have.